Welcome to Inspiring Heartfelt Conversations. My name is Barbara Morningstar. This series is presented by In Autumn's Cocoon, which offers education on a range of end-of-life topics in the form of talks, workshops, and courses. Today, my guest is Dr. Robert Twycross. 2021 marks the anniversary of his distinguished 50-year career in furthering our understanding of effective pain management and the use of drugs in hospice palliative care. He is the Emeritus Clinical Reader in Palliative Medicine at Oxford University in the UK. Welcome, Robert. It's wonderful to have you here today.
Well, I'm very pleased to be able to join you, and it's good to be able to mark my 50th anniversary in yet another way. Thank you.
Yes, lovely. So I'm going to dive right into the beginnings of this journey that you went on and ask you, who was the person that had the most profound effect on your life?
Well, looking back, I obviously, apart from my wife, but I can only say Cicely Saunders. Cicely Saunders, recognized worldwide as the founder of the Hospice and Palliative Care movement. She changed my life forever, and that's what I'm celebrating, 50 years in palliative care in 2021.
So can you tell us a little bit more about St. Christopher's and your role there with Dame Cicely?
Well, in a sense, although I formally came into palliative care in 1971, I first met her in 1963, before St. Christopher's Hospice in South London was open, and before I was qualified. I was still halfway through my medical training. She was planning to build St. Christopher's and had started, committees and fundraising and so on, but it was not yet established. I don't know. I mean, it's all history, and history is forgotten by most people. But the point is, she started off as a nurse. That was at the beginning of the Second World War. Then, because of back problems, she transferred to social work. And then working in hospital as a social worker in London, she was talking to the consultant physician with whom she was mostly connected about the neglect of the dying as she saw it as a social worker. And he said, Cicely, if you want to change doctors, you have to become a doctor yourself. So there she was. She hadn't done science subjects at school. But anyway, the end result was, at the age of about 38, in about 1958 or thereabouts, she qualified as a doctor. But the motivation for that was a meeting with a Polish patient in about 1948, and she would visit him and obviously listen and respond to his distress, because here he was, a relatively young man dying away from his homeland, and they obviously felt, or it prompted her to reflect on many of the dying patients she'd been in touch with, and she felt they were being neglected. We have big wards with 20, 24 beds or more, and you then have maybe 4 or 6 single rooms, which we call side rooms. And he may well have been in a side room, but in a sense that can make you more isolated. It's easier for the ward round to ignore you, as often happened. We don't want to trouble him, they pass on. So she recognized that many dying patients felt isolated and abandoned. And the isolation and the abandonment was almost worse than anything else. Anyway, she decided that to set up a hospice, a separate institution, separate from the National Health Service, and demonstrate what could and should be done was the way forward. And then, having established a base, a teaching center, also committed to research, then she could feed back into the National Health Service, and then that would become more mainstream. Now, the word hospice was chosen because it's a medieval term over here. I think you had it in Canada, but here it meant a sort of overnight way station for pilgrims on the way to a pilgrim site. Though I think some people stayed for longer if they will, and I imagine some people died. And then as things developed, you got a few hospices still, and you got the modern hospital. But some hospices continued, or some hospices were recreated in the 19th century. And Cicely, as a volunteer, and then after she qualified as a doctor, was attached to one such hospice in northeast London, St. Joseph's. And because of St. Joseph's Hospice, she called St. Christopher's Hospice. She liked the she liked the image of a way station for pilgrims en route. So St. Christopher's Hospice was opened in 1967, 54-bed hospice in South London, beautiful place, for the norm, a little extravagant, but it was beautiful. And it was fantastic what she did. And then, as soon she'd already started teaching because she was lecturing, people were lecturing, she was writing by request. So that continued alongside the patient care. And then she had to get down to research. And she, in fact, approached me, I think, in December 1967, because we'd met when I was a medical student in 1963. And I'd expressed my interest in various ways, and we'd communicated on and off. She said, Robert, would you like to consider applying for a research post? Well, I'd only been qualified, 2 years? And I said, well, actually, I need to become a rounded general physician before I move into palliative care. So thank you very much, but not yet. And then it would be 3 years later, I got another letter saying, our research fellow who I appointed a year ago has tragically died. Wow. And would you consider applying? So I read the letter twice and laughed and said to myself, yes. And the end result was I moved to St. Christopher's on March the 1st, 1971 as research fellow in therapeutics, and was there for 5 or so years before coming back to Oxford.
It's just fascinating, all her disciplines coming together to help create the foundation. Definitely. To look at it from different points of view, right? And
she, of course, knew that patients needed more than what we call biomedical, disease-focused care. She was holistic. She knew that it was the person who needed caring, particularly when they're dying. So she was ideal: nurse, social worker, doctor.
Well, so let's then go into one of my next questions around suffering, because that kind of bridges. How would you define suffering as you see people in end-of-life care? It's a bit of a big question, but how would you define it?
Okay, it's a big question. And first of all, I'll refer to Eric Cassell. Eric Cassell wrote a lot about suffering, yes, way back in the 1980s, and then his book subsequently. And it was very helpful in focusing on the person. I gather, though I haven't seen the detail, I gather Eric has recently died. But he said something like this: that a person suffers when they feel threatened, when their personal integrity is threatened. Okay. And he told several stories, I imagine, but the one I remember is a woman with breast cancer, with bone secondaries, who had fallen and fractured her leg, her femur, and she was surrounded by several experts who came to look at what was the best way of managing her broken femur. Well, maybe today it would be more straightforward, but in those days it wasn't quite so cut and dried. And what caused her the most distress was not the fact that she had pain when she moved, but the fact that these specialist doctors were arguing among themselves as to what was the best thing to do with her, or to do with her leg. So he pointed out, that it's not pain necessarily, it's not the physical symptoms necessarily which causes suffering, or the worst part of the integral suffering. It was a threat to one's person. I hope that makes sense. It made sense to me. And I think it's very important to think about that. But, the more you read, or the more I read, and I love reading about patients' experiences, that's how you begin to understand things. Of course, if I was still in practice, I'd have the opportunity of sitting and listening to them. But now it's reading their narratives. Look, people in hospital, if they're surrounded by doctors and staff who are trained in the biomedical model, trained to analyze what's going on from a physical point of view and work to cure or contain that disease, then I don't know, because of the pressures or because of the whole system, it's got into a very physical biomedical model, and they can ignore the person. So if you're there incurable, and things are progressively going wrong, even if it's talking about 6 months, a year, 2 years, but you can see the downward trajectory, then you can feel isolated. Because, I have stories here on my desk about patients who were in ICU. Now, ICU is vital for the right people. And it's been vital for thousands of people, hundreds of thousands of people with COVID over the last 2 years. And yet here is a cousin of a former colleague of mine who wrote from another country, but it could have been England, it could have been Canada, who said of his experience while he was in ICU on a ventilator, unable to speak, that the doctors would come and they would look at all his vital readings and talk about things among themselves, seemingly totally oblivious that he was there, totally oblivious. And that feeling of isolation and abandonment, a lack of recognition of me as a person, that is the cause of suffering at the end of the day. You may have pain, you may have this, you may have that. And who knows, having a tube down for ventilation is awful, awful, awful. But it's that feeling of isolation on top of it which causes the suffering.
I remember going to a lecture on this once at a national conference for hospice palliative care in Canada. And the woman had done lectures on suffering and then got breast cancer herself. And she decided to do a little experiment, and she watched everybody. And this wasn't scientific or double blind, but she said about 80% of the people did an okay job. But then she said, this was beautiful, Robert. She said 20% of the people were behind their eyes.
Really? What a nice comment.
Yeah, behind their eyes. And she said she knew they saw her. And she said it was those 20 people, that 20% that were behind their eyes that made all the difference for her, which is really, I think, bridging to what you're focusing on or highlighting here, and being seen by the staff instead of just being a kind of a diagnosis in front of them, right?
Right. And you see, people, wherever they come from into a hospice or palliative care program, most of them have at least some degree of feeling of abandonment, of isolation, of not being a person, at most being a patient. And they come in, and it's a whole attitude which is integral to a palliative care program. You can't run a palliative care program without that underlying ethos of what I call acceptance and affirmation, attitude of courtesy, respect, and all that goes with that, kindness, and we're actually working in partnership. You know, people talk about patient-centered care. Well, that can be interpreted in all sorts of ways, but we should be talking about partnership, relationship between people. And that means there is a partnership between the patient, yes, a person, and the caring team. And it's this whole attitude within a palliative care service, which means that patients feel a massive difference when they transfer from pre-palliative care to palliative care facility, or they have the support of palliative care staff visiting on general wards or at home. So, yes, and of course, there's acceptance and affirmation, which Carl Rogers in the 1950s called unconditional positive regard. No matter who you are, what you are accepted. No matter who you are, what you are a person of value. And we will do all we can to support you during this difficult time. So whether you call it acceptance and affirmation or unconditional positive regard, that is, you know, you can't get away from that. Without that, you haven't got palliative care. And we possibly don't talk about it enough because, you know, we don't think to talk about it enough, but that's where we have to start in teaching our medical students. I always think about teaching medical students because I'm a doctor, but I should say perhaps teaching healthcare workers. So yes, that's what makes a difference. And of course, when you think about Cicely Saunders' total pain, which is just an image of suffering, physical, psychological, social, and spiritual, existential, then you see, what are we doing about spiritual care? What are we doing about existential concerns? Well, it's all gathered up in the underlying ethos. We can't not offer support, which is spiritual. And I think we have to recognize that. A lot of people do research into spiritual care now, but of course they're looking at, well, does this intervention work? Does that intervention work? But okay, that's, you know, on top. So Harvey Chokanov's dignity therapy and Bill Breitbart's meaning therapy, they are important, but you know, that's a specialist icing on the cake, if you like. The people, 10% who need extra psychotherapeutic input of some description to help them cope with what is overwhelming them. But for the most part, spiritual care is just intrinsic and it flows. And as we've said for decades, listen, listen, listen. Listen to your patient. Let them tell you their story. And they will find that they have hope restored, because the basic hope of the human being is not to be cured. The basic hope is, in this difficult place I find I am, I will not be abandoned. And hospice care intrinsically demonstrates that we will not abandon you. We welcome you, and we will stick with you no matter what happens to the end.
It's a deep honoring and, as you say, a reverence for the life in front of you, the individual in front of you, until the end of their physical life. It's beautiful. It's beautiful. What about in whole person care, in this relationship element? I've seen in some of your presentations, you acknowledge the suffering of the caregiver and the family. How much is the caregiver and family important in acknowledging in whole person care? While we're focusing on the person dying, but these are deep relationships involved too, and support, right? So,
well, yes, the family do need support too, and we always say palliative care is care of the patient and his or her family, meaning the people who are close and important to them. Now, this is where you need team. In other words, it's not just me as a doctor, it's at least me and a specialist nurse. But let's hope we have a much broader healthcare team. And it's a healthcare team collectively who are offering support to the collective needs of a family. And I always thought, well, Robert, you don't give as much time to the relatives as you might. And I just, because I like every human being, I can only do a certain amount in 24 hours. But I rested, I felt reassured because I knew there were other members of the team who would be supporting the family in different ways. And I perhaps had to concentrate on dealing primarily with the physical symptoms.
Well, I think that's the beauty too of Cicely having a background in social work. And because you have social workers on the team and hospice volunteers and music therapists. And so I think that's the collaborative wisdom and beauty of how this has been created. As you said, the whole team together helps to hold the grace of the dimensions of this person as they're going through the experience. And the doctor cannot do, I have a lot of friends who are beautiful palliative physicians and leaders in our region, and they are so grateful for the team because they can't carry it all themselves, right? As you're just expressing. So,
but I'm a human being. And the more you work with and listen to patients, the more that innate capability called empathy grows. And that means I can put myself in the other person's shoes to a certain extent. I can imagine what it might be like for them to be in the place they are. And that empathy leads to compassion, which is practical, active kindness. And compassion says, no matter what happens, I am going to stick by you. I may not have all the answers. I can't wipe away all tears, far from it, but I'm going to stick by you. Now that is costly because you too, in a sense, do you get hurt by it? Well, it affects you. I know that all the negatives we came up with, day after day, week after week, okay, there were lots of positives, but all the negatives, something goes down deep into the subconscious. And, I don't know whether I'll ever, clear out or the negative junk in my subconscious. I do know that I get more upset than anyone else at a funeral. That's, I think, one of the side effects, inevitable sequela of doing palliative care. And of course, it can lead to burnout, but burnout need not be fatal, as I know from my own experience.
Mm-hmm. Mm. Well, as you say, we're being compassionate to those in the bed in front of us, but we're human too. And one day too, we will be there. So it touches in on the depth of our hearts and humanity as it's mirrored to us as they're in front of us, right? So beautifully said. Okay, so I just want to move a little bit into the place that had the most effect on you. Can you tell us a little bit about your next stage after St. Christopher's and your role in this place that had a deep effect on you and your life?
Well, Cicely Saunders was a great advocate, and she had lots of contacts in high places. So even before St. Christopher's was open, a lot of people knew about it. And she was able to get government grants for the research and that sort of thing. So, the word got around, if I could put it that way, but we had a cancer support society, not the Cancer Research Society or whatever, but the National Society for Cancer Relief. And they would provide support for patients from about 1910 in their homes and so on during their terminal phase. But the new executive who came in about 1970, he must have heard of palliative care. And he said, wow, we should think in terms of working in collaboration with the National Health Service and offer to build units on NHS campuses, provided that the NHS will take over the running costs once it's open. So the first one, I think, opened in 1974. I moved back to Oxford in 1976 when there were 2 more units which were ready for opening. So I moved back to Oxford to a purpose-built palliative care unit on one of the university hospital campuses, and I became the first medical director there. It was named after the benefactor who donated the money for the building, who was the president of this Cancer Relief Society, Sir Michael Sobell. And I was there for the next 25 years, up to 2001. So that inevitably had the major impact on my life. It couldn't be otherwise.
Mm-hmm. Well, so let's move now into the area you're most well known for, and we are blessed for your research, and that is around the development of the protocols for end-of-life medications. And you created the Palliative Formulary. Can you tell us a little bit about how these protocols came about and were developed? Very intricate. So you can give us a little bit of insight into that.
Now, ever since I was a medical student, I've been interested in drugs, in therapeutics. And that's why I ended up, or partly why I ended up at St. Christopher's as a research fellow in therapeutics. And my interest in drugs has continued and developed. And that inevitably, as the service in Oxford widened and we had a second consultant joining us in 1988, I said, come on, we're having young doctors coming through for 3-month attachments and moving on. We've got to, document our drugs of choice. And so that's what we did. And we sort of had, 20, 30, 40 pages of A4 type, which we would update each year with the drugs which were our favorites for different situations and why they were, and so on. And then one of our training registrars, who was with us for 4 years because she was training to be a specialist, she said, "Why don't you publish it?" So I said, "Well, maybe we should. We're now, in 1995 or something like that." Well, I asked another registrar who was with me at the time if he would collaborate, and we started work on it. And of course, the 50 pages or whatever it was of A4 became a book, and we called it the Palliative Care Formulary, because the book of drugs, which every doctor used to receive every 6 months from the government in those days, was called the British National Formulary. So we called ours the Palliative Care Formulary. Well, we started work on it in 1995. I think the first edition was published in 1997. So we're up to 24 years. And we're, on edition 7, though, I really backed off, if you like, after edition 6. So it's come out roughly every 3 years. And that has grown. We obviously have one or two younger enthusiastic collaborators, and we have an editorial board who can contribute and help. But it's a massive work. We hoped at one time, we did produce one edition in Canada, and we produced 2 editions in the USA, which was probably a mistake. But we then concentrated on the British edition, the English edition, and that's where it's gone on. But you see, people in other countries do find it of value, and do refer to it lots, and that's very humbling. But of course, writing a book on drugs, well, it's a challenge. You can't get it wrong. So yes, new information comes out, has to be incorporated, and so on. So it's a massive work. And I take my hat off to Andrew Wilcock and Claire Stark-Toller and Paul Howard, the doctors who have collaborated most with us, and Sarah Charlesworth, a pharmacist, who has, in a sense, held us all together.
Well, I think I mentioned to you, one of my colleagues when I was working full-time in hospice was Bruce Kennedy in Canada, and he's an amazing palliative pharmacist, and he helped in the revisions and the edit for the Canadian version. And that's when I first heard about you and your work, and developed a great respect for the detail and the research that backed it, and just watched Bruce's work and his reverence for all that you had created, because it was invaluable to our teams in the country that I live in. So it's not just in Britain, it's spread out, to different parts of the world. So thank you for that. But I found a deeper respect even through watching him and his honoring of your work and all that your team had done to just lay the foundation for all of that deeper capacity to help people become pain managed at end of life. So
it's very important, obviously, no doubt about that. But pain management, symptom management is more than the use of drugs.
Exactly.
But you've got to have the doctor who understands drugs and can use drugs. Otherwise, drugs used in a second-rate way don't do so much good, and possibly, almost inevitably, will create more unwanted effects. So you've got to know your stuff, but they have to be used within a broad spectrum approach to symptom control. And even at the end of life, you have to say, is there anything I can correct? But as that becomes less and less in terms of correcting some physical or biochemical abnormality, don't forget the place of palliative radiotherapy and pain control. You have to think of non-drug measures as well as drug measures. But so often you have a course and it says pain control and it's drugs. And that's not right. I mean, apart for obvious reasons. Pain is caused by more than the cancer. I think 20% of our patients had significant muscular pain, chronic, harsh muscle spasm, chronic cramp. And if you don't recognize it and you give morphine for it, you're wasting everybody's time and not curing or relieving the pain. But of course, you've got to identify by clinical observation, clinical examination, reviewing back tests which have been done, coming up with a likely diagnosis and saying, look, I think this pain is caused by this, and this pain is caused by that, and this is what we're going to do. This attention to detail is absolutely vital. We've already said that listen to the patient, respect the patient is absolutely vital, but attention to detail, indeed, in listening to the patient and also in inquiring of the patient in relation to symptom management, it's absolutely vital. There's no place for a simple algorithm. You've got pain. This is what you need. That drug isn't causing relief, getting relief. We need to move up the ladder. Sometimes it's necessary to move down the ladder, and sometimes it's necessary to move to another ladder. So, attention to detail, the other sort of, whatever you like to say, golden thread running through palliative care. And I'm afraid that a lot of people, are they in palliative care or are they the generalists who are doing their bit to use palliative care within their practice? I'm afraid that there are a lot of people out there who don't pay attention to detail.
Well, I've shared this with you with my husband when he died. He had 3 primary cancers and 2 of them were marrow cancers. And so his spine was challenged and very difficult for pain management. But even when the pain was managed, I was even from a background in hospice palliative care and work. He had lost a first wife to cancer and a child to leukemia at 7.5. And when the physical pain was managed, then often the volume of the deeper wound and pain and grief from the death of the child and the death of the first wife would come up. So we had to give space to hold that in that picture of total pain as he was healing in body and spirit and heart, right? So firsthand experience of the depth of that and how much love and compassion and care it calls on you as somebody's going through such a tender and vulnerable time, right? So
I agree. Now, sometimes, of course, it's very difficult to relieve the pain, even with the right drugs, because of all that background. But on the other hand, if you can relieve the background pain, or bring it down to tolerable levels, then that gives the patient space to think about all these other matters. And I know patients for whom the agonizing pain almost saved them from having to face up to all these other issues. So again, pain control can be difficult. And the need to listen and the need to respond appropriately is vital.
Mm-hmm. So I'm just going to ask one question, or last question around the medications, and we're going to move on to some other beautiful elements of your career and influence. Doctors are used, and pharmacists in palliative care are used to dealing with these narcotic medications, but for the average person, it can bring up a lot of fear. So could you speak to some of the common misconceptions to help people soften the fear around the use of the narcotics a little bit?
Yes, I'm aware that many patients are fearful of what we would prefer to call opioids, particularly the word morphine. I think it's less in the United Kingdom. Well, it's strange, isn't it? Because if you have an accident and you're in bad pain, when you go to accident and emergency department, you're likely to be given morphine. Mm-hmm. And people don't, blink an eye about that, as with my youngest daughter 2 days ago. Mm. And of course, if you have a heart attack, you get morphine after an operation, you get morphine or one of the alternatives. People don't bat an eyelid about that. But it's when you sit down and say, well, look, I think we need to use something stronger here. And I think in your case, we should use some morphine. Now, I think for most people, that does bring them up sharp. What? Morphine? Mm. Does that mean I'm dying? But of course it doesn't. We've just heard about it in relation to accident and emergency and post-operative and so on. But it's interesting. It's the context, isn't it? They associate it with dying. And I imagine quite rightly, because all the stuff which is on, whatever you like to call it, in the social media, and the idea that, when you're dying, you have a morphine drip and that sort of thing. Oh, he's been put on a morphine drip. Well, you can be on morphine for years. You're only on a morphine drip because you need morphine and you can't easily swallow it. Mm-hmm. So I've had patients who've been rightly on morphine for 10 years. Mm-hmm. Now, most of my patients didn't survive 10 years, but I'm trying to make a point. So somehow you have to say, well, I think we need to use morphine. Now, a lot of patients, a lot of doctors get round that by prescribing an alternative, fentanyl, oxycodone. In North America, I think hydromorphone and so on. Generic preparations of morphine generally are cheaper than other preparations, and we do have to bear that in mind. But okay, so when you're explaining it to someone, I think we should use morphine. How does that feel to you? And they can then express their fears, and you can talk about its use in accident, emergency, and post-op, and quieten their fears, you hope. And the fact that your specialist nurse is going to phone them the next day and visit the day after to see how things are going, because it does need careful introduction. 90%, 95% get constipated. And if you don't warn them about that, you don't introduce a laxative, then, they may well give it up after 3 days, because they just can't budge, on the toilet. And some people get nausea, particularly during the first week. So, there's a lot of discussion and writing down that, because most of my patients I met first time in outpatients, writing down their medication clearly, simply on some form which is prepared to make that more straightforward. Your take-home medication chart and explaining it and so on, and the phone call by the nurse and a visit by the nurse and a repeat visit a week later to your clinic, that is all vital in this attention to detail in order to get people over the hump if they are concerned about morphine.
Well, and I think I wanted to bring this up to help people understand the depth, as you said, of the research involved, the safety measures in place, the monitoring of it, and the attention to safety and care throughout the introduction of the medications, especially when someone's vulnerable. I started in hospice close to 30 years ago, and I've watched physicians and pharmacists, and it's an art. And I've seen people in such discomfort bring all of the, not just the medication, but as you say, the whole person care element, and seeing just beauty happen in the calming of the body, of the spirit, and the journey to end of life being a very peaceful, supported, loving one. So I don't want to, I wanted to bring that in a way to help people understand the whole structure in place along with the medications, but the safety and the detailed background to the use of the medications as well to soften their fears.
Yes. Morphine is a very safe drug.
Exactly.
In fact, it's very difficult to kill someone with morphine.
Exactly.
Because if you take too much morphine, then you just go to sleep for a couple of hours and wake up, after delightful rest. That's what happened to me recovering from a hernia operation at home about 40 years ago. I couldn't remember whether I'd taken the dose. So I said, I'm not going to have that awful pain. So I took another dose and, in 10 minutes, I was fast asleep. Yes, the idea of he's on a morphine drip, it's not because the morphine is going to be vicious and, kill the person. It's because they're too weak to take it by mouth, and that's the kindest way of giving it. There's a lot of evidence, anecdotal evidence, yes, that good pain relief, I think it's more than anecdotal because it was done very thoroughly in the post-operative scene where post-operative pain in the old days was very badly managed. But, good post-operative pain control meant the patients recovered better and got home 2 or 3 days sooner. So if you transpose that sort of thinking to the end of life, I've no doubt that good pain control prolongs the life of many of our patients. And again, it's against this background of this palliative care philosophy, the practice of. Way back in 1986, we had an intensivist from Norway who came for 6 months because he'd started, he was one of the many anesthesiologists around the world who were involved in chronic pain management, largely non-malignant. And he wanted to get some experience within a palliative care unit. So he came over for 6 months. And a couple of years later, I overheard him say to someone, since I went to Sobell House in Oxford, my doses of morphine have been much lower than they were before. And that's important because if you're not looking after the whole person, if you're not looking at a person and relating to a person and building that relationship of trust and support and hope, then the fears continue. And the barrier to pain relief, goes up, and the pain becomes, or sometimes, unrelievable. So morphine has to be given on top of basic palliative care approach. It's a very safe drug. if it's monitored properly, and in a sense, no one need fear it. Now, I know in North America, and possibly in this country to a certain extent, there does seem to be an increased fear because maybe 10, 20 years ago, because doctors had been told that it was safe to use in dying patients, they started using it for patients with all sorts of chronic pain. Now, all sorts of chronic pain they do sometimes, but generally they don't benefit much by morphine. So you get someone who is having a drug which isn't really getting to the root of their particular problem, but it gives them some sort of relief and diversion. And they do become or can become psychologically dependent on them, which is addiction. And then you run into problems. What shall I say? People have started being more restrictive in their use of morphine in the United States. And that, of course, is good if it's restricted in relation to patients who really shouldn't have it. But if it knocks back, as I gather it has to a certain extent in some areas, on it being harder for patients with cancer who really need it, if it means that they are finding it harder to get it or to have it prescribed, then that, of course, is a tragedy. But I just hope that with good education and good understanding and good teaching about pain management, that problem will be overcome. But morphine is safe. If it's the right drug for you, you will not become addicted to it. Okay, if you're on a big dose, you can't necessarily stop it overnight because then you get what we call withdrawal symptoms. But you can phase it down over a few weeks or a couple of months if something has happened to remove the underlying pain, another form of treatment. But addiction is not or should not be a problem.
Right. So the key here is align with your beautiful palliative care team in all facets of whole person care, and the gift of that, especially at end of life. I mean, it's not just the medication, it's all the dimensions of the individual in pain management and comfort care, right? So,
right.
Okay, so we're going to move on to the next question. And one of the beautiful parts of your career was working with the World Health Organization and to help educate people in palliative care worldwide. You've traveled to over 40 countries to teach and educate people in palliative medicine and palliative care. What was it like? We talk a lot about diversity now. What was it like to go to all these different countries with different cultures and religions? It must have been a fascinating experience for you.
Well, it was. In fact, the first time I went abroad was 1973. There I was, the age of, you could probably work it out, 32. I'd never been abroad. And my first trip was to Greece, to an international conference where I spoke about the use of morphine and so on, cancer pain relief. It was a therapeutics conference. So, yes, but the interesting thing was I was reflecting. I don't know, I'd say that I was a born teacher. Now, it's very difficult to evaluate yourself, and I probably shouldn't be doing it. But when I look back to when I was a general medical registrar working for my higher diploma, the membership of the Royal College of Physicians, I lectured to the nurses on infectious diseases, mumps and measles and so on. And there I was writing lecture notes, which I handed out. And I was asked to, this is an aside, I was asked to teach some young people about first aid. And again, I found I wrote the lecture notes and I always tried to simplify it. And there's always well, up to a point, you can simplify it, how you express it and so on. So I was looking back the other day and I say, yes, Robert, you must be a born teacher. You know, teaching is in your genes. And so I think I naturally moved into teaching in palliative care. And, you know, my life, what would my life have been without it? I don't know. And then, of course, I started writing. And once you start writing, if you carry forward the same attempts at simplicity and clarity, which you did in the lecture notes, then you develop a style which people find is accessible. So again, my genes almost dictated that I became a teacher and a writer. And that was at first on top of mainly research with a small amount of patient care, and then with patient care and a small amount of research. And then the teaching got larger and larger in the 1990s. And I said it's more important to do that than to continue research.
Well, even, you know, before our recording, you spoke of going to Africa and were there during the apartheid. And in another writing that you spoke of being in Africa during the HIV, you know, severe element of the epidemic back then. I can't imagine some of the things you've seen in the travels and how you've been impacted as a human being as you've gone into these different areas.
You're quite right. I'm going to go back to well, we mentioned Greece, and there were obviously other foreign trips, but the first time I went, I think, well, no, I'd been to North America, but, you know, that's the same sort of background to Western Europe. So, you know, it wasn't that much different, though it is different. But in 1983, I think that was the first time I went to Japan. And I thought to myself, well, you know, there are very few Christians in Japan. And hospice care has been undergirded by a Christian philosophy of compassion and care. And, but, you know, that won't make sense to 99% of my audience in Japan. So what is it I've got to get across to them? So in that situation, I said, to work in palliative care, you've got to believe in life. In other words, that life does have meaning and purpose, even if you're not sure about it. And because it has meaning and purpose, we will continue to support and cherish our patients until they die. We will not reject them and say, you're on the junk heap. So this belief in life is absolutely vital. And I suppose I've carried that forward into other situations. India is very interesting. I've been to India dozens of times, you know, running courses and so on. Most of Indians are Hindu, some Sikh and Jains, and quite a lot of Muslims, and depending on where you are in the country, few or quite a lot of Christians. And you tend to avoid the subject of religion directly because it can be so inflammatory, particularly under the present government there. But you can get around that. You know, if you're conveying this message, you know, supporting the patient until they die, and showing that you're doing it. You don't have to say necessarily you need to believe in life, but I did say that in Japan. But a lot of people, well, perhaps most people, could I say all people, have an innate capacity for love and compassion. And what you're really doing is empowering people to give them something to do in the awful situation of someone dying in pain and being in absolute agony and distress. You're showing them what compassion in action can do. So, yes, we just accept that people around the world, particularly they turn up for a palliative care conference, have this compassion which is common to all human beings. So in some, it might be somewhat shrouded. So we're giving people the weapons to use their compassion in a compassionate, constructive, supportive way.
That's beautiful, actually. Yeah, thank you for that. So let's move a little bit more into that spiritual or existential realm. We're hearing a lot more about deathbed visions and dreams. What are your thoughts on deathbed visions and dreams?
Well, of course, I've lived my life in palliative care alongside people like Raymond Moody and Bruce Grayson and others who have initially concentrated on near-death experiences and out-of-the-body experiences. And I read Raymond Moody's first book whenever it came out, in probably around about 1980. And, you know, I've always accepted it. I mean, I never believed you could explain it away on the grounds of brain starved of oxygen and so on. So I've never had a problem with it. And the fact that people have visions and dreams and so on around the time they're dying, I've never had a problem with that. You know, the fact that people may have a vision of a loved one visiting them and so on, it's always just been part of life for me. And perhaps I didn't pay enough attention to it. I remember one patient who would become, unrousable for 2 hours, and it turned out that she was having an out-of-the-body experience. So it's just been natural. But some of the stories I've read recently, have been quite phenomenal, and just support all this information, which I think should be commonplace. I know not everyone has deathbed visions and dreams, but they are common enough for us to be to need to know about them and to be aware of them, and to respond to patients and so on, so that they feel supported. And of course, it's a clue. If you start seeing your grandmother or your deceased brother either in the room or in a dream, then it's usually an indication that you're going to die soon. And for most people, they are reassured by that. They don't say, go away, I don't want to die. They're reassured by it. And it's important that we help our patients acknowledge that. And again, it comes back to listening, active listening, asking the right question at the right time and so on. So, yes, very important to know about, and no problem with it. But of course, the book you reminded me of a few months ago, which had been on my shelf unread for 10 years, Glimpses of Eternity, the shared death experiences where a loved one would either be joined in the vision or indeed, as the patient died, sense the spirit leaving, and they would too have an out-of-the-body experience, and they would accompany a patient along this tunnel or whatever. But at some point, they came to the parting of the ways. The patient went on, but the person who was with them returned to their body. Indeed, a beautiful story of someone who commented on their out-of-the-body experience. They looked down and they could see themselves, and they could see the corpse of their kinsperson who had just died. So again, you can't explain these away. This is part of reality for human beings. And I think it has all sorts of implications.
So how has the exposure to all of this affected your own personal journey around spirituality or the existential domain of life?
Well, I was brought up in a Christian home, and in fact, have a strong Christian commitment. But of course, as you get older, you believe less, but what you do believe, you believe more and more. So, you get rid of a lot of the ecclesiastical junk and get back to the basic message, which I believe Jesus taught us. Indeed, about caring for the lost, the least, and the lonely, and so on, and practical compassion. His teaching in some senses wasn't wildly different from some of the other philosophers of that period of human history, but he didn't come to give a whole lot of philosophy lectures. He came to show us how to live a compassionate life. And more than that, I believe, as a Christian, he came to show us what God is like. That, human beings are flawed, yes. The world is often in a mess, but God is involved in that. And indeed, God suffers alongside human beings. And this is the basic of my Christian understanding. And that, of course, is a great support and help to me.
So you've seen so much death. You've companioned so many people to end of life. I'm sure you've had this question before. Are you afraid of the dying process or of death?
Well, I think we're all programmed to be fearful of death. And I know in the early 1970s, I'd say, well, if you're working with the dying, you've got to overcome your fear of death. But I changed that, I think, in the 1980s to saying, if you're working with the dying, you've got to overcome your fear of people who are dying. You've got to overcome your fear because, of course, out there in the wild world, anyone who is dying, oh gosh, danger, 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 run away. But we've got to overcome that primitive urge to run away from dying and the sense that there's something tragic going on, I better not catch it. So, yes, no, we all have to have a fear of death. Otherwise, we'd walk in front of buses and that sort of thing. So we need a fear of death. It's part of the survival instinct. And, I don't know how I'm going to react when I am on my final journey. I don't know. It might be quite a rough time because all that subconscious stuff, which is still there, waiting to surge up.
So we're coming to the end here. What do you think the greatest gift of palliative care is to people?
I am going back to the beginning. It's a restoration of that most deep, primitive hope. I will not be abandoned. I will not be isolated. I will be accepted, respected, and treated like a valuable human being. And obviously all that comes leads to in terms of practical action.
So I have a signature question that I ask everyone at the end, and that is, how has your heart been changed by this work?
I think that's a very difficult question. But from what I've said, you can see that it's had a really massive impact on my life. And when I look back, we were never taught anything about communication skills. And like many people of my generation, if we really were honest, we've got a lot of horror stories about how badly we communicated in those early days. So the impact on my life, well, obviously I've learned to listen. Obviously my empathy has been developed from that basic innate cognitive ability. And I hope I am a more compassionate, kinder person, but I don't know.
Well, thank you, Robert. I just want to thank you again for coming today. I was telling you that years ago I went to London. I was thinking of moving to London, England, and had the opportunity to go to Oxford, the town, for a day. And it was just before Christmas with the dusting of snow and all the beautiful lights. Had the best scones and tea and afternoon tea in a cafe there ever. Didn't get to go to the university though, but I've always thought it would be beautiful to go there, to just stand on the grounds with the rich history and the wisdom that's come out of that institution. So I just want to honor you for, being cradled in that and adding to the rich history of that institution and all the work you've done in end of life care. But as I said to Dr. Balfour-Mont, for both of you, I get a lot of emotion that comes up. Because of I started in hospice 30 years ago, and I've had loved ones who've died and benefited from all your work, as well as what I've seen and the work I do. So what you've brought forth in medicine and contributed to medicine, but more than anything to our common humanity and the relief of suffering at a very tender time, I just can't thank you enough. I just truly feel a depth of gratitude to you as a pioneer and all you've done for us. People forget this, don't understand the depth of it at times, but it truly is to be honored. And I've seen the beauty of it and the gift of it in my life. So I just want to thank you for that and taking the time to come today.
Well, my great pleasure, Barbara. Okay. My great pleasure.
Okay. Thank you.
Thank you.